All right. Well, do you have to push? We'll just get started here. So I'm Lindsey Clark. I'm one of the physician assistants here. I've been working here for 10 years now. So I've seen a lot of gout. I really like gout, but probably because I've never had it. Um, so we're going to talk about basically what is gout, what are the symptoms of gout, how is it diagnosed, how do you treat it, and then we'll just kind of touch on pseudo gout, which is a separate condition. So what is gout? Um, Basically, there are patients or people who have high levels of uric acid in their blood. It's called hyperuricemia. Now, lots of people have hyperuricemia and don't have gout. In fact, most patients with hyperuricemia don't have gout. But patients with gout have hyperuricemia. They have high uric acid levels in their blood. And when you have excess uric acid buildup, then it can these crystals can deposit in the joints and cause flares. So typically you would get recurrent inflammatory flares with gout. This can include joint pain. Typically with severe gout, over time, you develop these tophi, which are the accumulation of the uric acid crystals, and you'll see that later. And then this can even include uric acid kidney stones as a complication. So the stages of gout, there's the acute flare that can happen. Again, that's the inflammation of the joint. Sort of the common presentation of gout would be, does the pointer show up? No. So the big toe on the top picture. But gout can affect any joint. So in the bottom picture, you see the redness and swelling at the joint. And then you can kind of see those whitish bumps. Those are tophi. So those are that accumulation of the uric acid crystals that can develop over time. So stages of gout, a gout flare, like what you see. Then the period between flares is called the intercritical period. And during the intercritical period, there may be no symptoms. But most untreated patients with gout will have another episode within 2 years. So then the last stage of gout would be what we call chronic gouty arthritis and tophaceous gout. So this is sort of the chronic inflammation that can eventually develop with sort of chronic joint pain. Untreated gout can cause destruction of the joint, can cause, like I said, these tophi can develop in soft tissue areas. Again, we'll see more of that later. So the characteristic gout patient would be an adult male over 40. However, as women reach their 60s, 70s, there's much more incidence and it kind of evens out, males, females at that point. Premenopausal women have some protection from the estrogen. So that's the reasoning. So kind of like what we said, acute gout flare symptoms would be severe pain, redness, warmth, and swelling. Usually an initial flare would affect just one joint. And then again, commonly the base of the toe, but you see that bottom picture, that's a knee. So gout, like I said, it can affect any joint. Interestingly, some patients might notice that their flares often come on in the middle of the night or in the early morning. They think that is because of hormonal shifts that happen in the night, lower body temperature, decreased cortisol levels, and dehydration overnight. Again, gout would be more common in the lower extremities. A flare, usually the severity of the flare can increase over hours and then usually peaks around 12 to 24 hours. Even if a flare is not treated, it tends to go away on its own. It can take several days to a couple weeks, which if you've had gout, you probably would say you don't want to wait it out when medicine can help quickly, but it will typically go away on its own eventually. So what are some things that might provoke a gout flare? So there's the physiologic changes, so trauma. I had a patient bang his elbow on a desk and his gout flared in his elbow. Or some patients, they'll like stub their toe or kick their dresser and come in a couple days later with a gout flare. So surgery, any kind of surgery can induce a gout flare. Starvation, dehydration. There's dietary triggers, the high purine foods, so red meat, organ meats, liver, beer, alcohol, shellfish, and then like high fructose corn syrup, sweets, sugary drinks. And then there are drugs that can affect the uric acid concentration in the blood. So there's diuretics like water pills, hydrochlorothiazide, furosemide. Those things can affect the uric acid concentration in the blood and induce gout flare. But the problem is these medications are often used in conditions that are also high priority, so congestive heart failure, that it's needed. So in that case, they stay on the water pill, but again, you just adequately treat the gout. And then allopurinol, which we'll talk about, and other drugs can positively affect the uric acid concentration. So as mentioned above, again, alcohol can provoke a gout flare. And then hospitalization for any reason they find can increase risk for a gout flare. All right, complications of gout and or hyperuricemia. So there's kidney implications. If you have chronically high uric acid levels in the blood, both kidney stones or just a form of kidney disease. And this is what happens again without treating. So as time goes on, you have that constant deposition of the tophaceous material, so that the crystals that develop that kind of white chalky material into the joints, and the longer it's there can cause erosions in the joints and the bones, and evolve into that sort of chronic gouty arthritis. And like I said, much lower risk of these if you are on long-term gout treatment. So tophaceous gout, again, is the most severe form of gout. The tophi are kind of those white things that you see. Again, that's uric acid crystals in the joints, and then there's sort of this inflammatory response in the tissues, and so you get this sort of accumulation of material. And the tophi themselves really aren't painful, but you can see how they would affect function. So that first picture, that's a knee, and then a finger. Interestingly, you do see it on the ear occasionally, and then another finger. So how do you diagnose gout? So someone comes in, they have a big red swollen joint, they've never had it before. It could be lots of different things. And so, characteristically, yes, the big toe is affected with gout, but other things can cause that too. So how do you diagnose gout? The gold standard would be to aspirate fluid out of the joint, look at it under the microscope to visualize these uric acid crystals. Now, of course, you can imagine someone's excitement when you tell them you're going to put a needle into their red, hot, painful joint. And so it's a tough sell, but you sort of explain that if you're going to put someone on essentially a lifelong medication for gout, you better be sure that that's what you're treating. And so, yeah, so that's the gold standard. If it's a joint that you can put a needle into, the big toe is a small joint, but it's possible. And so now the nice thing is if you have a needle in there already, and you can confirm that there's no pus, like no infection, then you can go ahead and put some steroid into it while you're in there to help relieve the flare. So other ways that kind of, or other things that help us diagnose gout, you can get a uric acid level in the blood, but this wouldn't be diagnostic of gout, because there are people who can have increased uric acid levels, but not have gout. Now, if somebody has a high uric acid level and a characteristic joint flare, like gouty joint flare, then that kind of helps your case. But when you are in the middle of a flare, you can have a falsely low uric acid level. And so some patients will come see us, and they've been to urgent care, and they had a flare, and they had their blood taken, and the uric acid level was low, and we're told, no, it's not gout. But that's not accurate, because again, during a flare, the uric acid level sometimes is low. So we still get a uric acid level, just to kind of see, because if it's elevated, great. And then also a couple weeks later, when the flare has resolved, then we get the uric acid level as kind of a baseline for going forward. Let's see. So imaging, typically early in disease, there would not be any x-ray changes of gout. The damage that you can see on an x-ray would typically develop after having gout for some time. And so what can happen is, again, that sort of that chronic inflammation in a joint causes these erosions in the bones. The characteristic appearance of a gouty erosion would be what we call the overhanging edges. And so that's what they look for. So treatment. So we'll talk about acute treatment and kind of chronic long-term treatment. So the patient comes in, they have a red hot, swollen joint, painful. You aspirate, you see the crystals on exam, or maybe it's a patient who's had established gout. They come in with a flare. Of course, you want to treat the flare, make them feel better. And the sooner you start them on treatment, the more complete the flare will resolve. If they wait several days, then the treatment will still work, but it could take longer to completely resolve. And so ideally, the sooner the better. These are not in any particular order. They all are effective, but the options for treating an acute flare include NSAIDs, so anti-inflammatories, colchicine, a medicine that's been used a long time for gout, oral steroids like prednisone, or like a cortisone or steroid injection into the joint itself. There's different reasons for choosing the different options. So NSAIDs are a fine option in patients who don't have kidney disease or history of stomach ulcers or bleeds. You can't use, typically you'd want to avoid NSAIDs with someone who has like bad congestive heart failure, it's on blood thinners. So there's some contraindications to using them. But if that's not an issue, then that is an option. Indomethacin is a pretty potent NSAID. Side effects, again, can include stomach upset or headache. So it's sometimes given, but not as commonly because of the side effects. Colchicine, again, colchicine's been around a long time to help with gout. They used to prescribe it. They'd say take 1 an hour until your gout flare goes away or you get diarrhea. They don't do that anymore, luckily. So it's usually just twice a day for a gout flare. But side effects still can include some GI upset or diarrhea. Again, there's contraindications or cautions with this. If you have kidney disease, then you might not excrete it very well. Or if you use a statin, like a cholesterol medicine, there's a possible interaction with a statin and a colchicine. So still reasons to maybe not use it. And then it can be, we live in the US where drug costs are insane. And so this one, even though it's been around forever, can be very expensive, unfortunately. So sometimes cost affects the decision. So oral steroids, luckily prednisone, there's not a lot of contraindication, or there's not a lot of reasons not to use prednisone, fortunately, in patients who tolerate them. There's some mood changes sometimes in patients taking a lot of steroids. They can increase blood sugars short term when you're on them. That is something to consider. Fluid retention, that again, generally for a short term, that wouldn't be a huge issue. But if someone has uncontrolled diabetes, really bad blood sugars, you'd have to kind of think twice. And then if somebody has a coexistent infection, you'd want to kind of be cautious, since the prednisone can make it harder to fight an infection. And then the last option would be, again, a steroid injection into the joint itself, if you're not worried about infection. So again, if you have a new patient with a red hot swollen joint, and there's any concern about maybe an infection, then you wouldn't want to do a steroid injection because it would make that infection worse. But if it's somebody who's had established gout, maybe it's always in their big toe, it's not a surprise, then that would be an option. Side effects, I put increased blood sugars. The small amount of steroid that you would use for like a big toe injection wouldn't affect the blood sugars too significantly. A little bit more so if it was a big joint, because you'd use more steroid. But still, overall, it'd be less than oral prednisone. So those are the acute treatments for gout, what to do in the short term to get a patient feeling better. Now we talk about the long-term treatment of gout. And again, you wouldn't want to start any of the long-term options until the gout flare has resolved and you're kind of starting fresh, getting a baseline uric acid level to see kind of where you're at. The, the, the way the long-term treatment works is what we're trying to do is lower the uric acid level in the blood. So there are medicines that can do that, and there's a couple different kinds. And what these medicines do, they can, so patients who already have tophi, actually these medicines can even reduce the tophi. So once the tophi are there, doesn't mean they'll be there forever if they're adequately treated. Generally, the uric acid goal is less than 6. In patients who have tophi, the uric acid goal will be less than 5. Again, you'd wait a couple weeks to start this. Again, expected to be lifelong because generally, if you stop the treatment, a patient's likely going to flare. And then I kind of put in here, unless instructed by the provider treating your gout, do not stop taking your medication at any time. There's some different methods out there. Patients will come in and they've gone in and seen somebody else for their gout, and they were told to stop their medicine during a flare, or that, which is not true. So don't stop it ever. So the different classes of medicines that will lower uric acid, one of them is called the xanthine oxidase inhibitors. So that includes allopurinol and febuxostat, kind of the most common medicines used. And then there's the uricosuric agents called one called probenecid, which is used but maybe not quite as commonly, and we'll go over why. So the xanthine oxidase inhibitors basically, because in patients with high uric acid in the blood, there's 2 reasons for that. One reason is that your body makes too much uric acid, and one reason is that your body doesn't excrete uric acid well. So this medicine helps to reduce the production of uric acid. So allopurinol, again, is typically the first-line treatment. You'd start a low dose, you titrate up every few weeks. Possible side effects, rash, maybe affects blood counts, diarrhea, elevated liver tests. These aren't common, but things to look out for. And then there are some drug interactions you'd have to, that your doctor would want to just make sure that is not an issue. Febuxostat, that's the other xanthine oxidase inhibitor, works similarly. Same thing, you start at a low dose, titrate up if needed. There's some thought that maybe this one is safer in kidney disease, but more recent literature doesn't necessarily support that. The allopurinol generally is safe in kidney disease. This one can be more expensive than the allopurinol. And then this one does have a black box warning for cardiac events. So it's one of those things you want to kind of talk to your patient about their risks and their history, and kind of weigh risk benefit. So side effects, same, maybe liver test abnormalities, nausea, joint pain, rash. So the other group of medicines that can be used to lower uric acid is the uricosuric agents, and this one works differently. This one helps you excrete that excess uric acid. So probenecid would be the one in this class. Not used as much because there's a lot of drug interactions, probenecid with other things, and so again, the pharmacy and your provider need to just kind of take a close look at that. Also, this one, you have to take it multiple times a day, which is not convenient for patients. If you have moderate to severe kidney disease, it probably isn't going to work very well for you. And then side effects, rash, GI upset, maybe kidney stones. So what shouldn't use in a history of kidney stones. So as far as how these medicines work, I came across this and kind of liked it. So just to review, so purines, those are the chemical compounds that our body makes, and we get them through food. Purines get broken down. Uric acid is one of the waste products. And again, so that uric acid is what increases in patients with hyperuricemia and gout. So you got your purines, your uric acid waste product. The uric acid crystals collect in the joints, and you get gout. So allopurinol, the medicine that helps to prevent forming uric acid, kind of works here to stop the formation of uric acid. And then probenecid helps the uric acid to excrete more readily. And then again, the medicines to help with the gout flare, the NSAIDs, the colchicine, and the steroids. Now, when starting a long-term treatment, a uric acid lowering medication, We also use what we call a prophylactic medication, prophylactic, prevent disease. So something in addition to the uric acid lowering medicine to help prevent a flare, because allopurinol, febuxostat, these medications will not reduce your risk of a gout flare in the early stages. All they're doing is to help lower your uric acid level, which will take some time. So in the meantime, we need to use something that will prevent you from flaring. So we use what we call a prophylactic medication. So these are medicines similar to what we would use in a flare. So colchicine, anti-inflammatory, prednisone. Again, the choice depends on a person's comorbidities or other medications that they take. Um, Oftentimes, it's just low doses of these compared to the doses we would use in a flare. And so, like colchicine, it would just be one a day for prophylactic use, sometimes every other day in kidney disease. Anti-inflammatory one a day. Low dose prednisone works. It's just not preferred because long-term use of prednisone, even low doses, can cause other issues, increased blood sugars and thin your bones and increased pressures in your eyes. So in patients who cannot use colchicine or NSAIDs, sometimes low dose prednisone might be used. So again, this would be continued for several months while we're working to lower the uric acid level to prevent you from flaring. So once we got your uric acid level to goal, then another 3 to 6 months later, as long as you're not flaring, then you can stop the prophylactic medicine. I put this one in here. There's another drug. It's called, the brand name's Krystexxa pegloticase. This is for really severe gout, not responding to the other options. But this is an IV infusion medicine. It's every couple of months, I think. It works very quickly to reduce flares and reduce tophus, improve function. But there's a pretty high risk of infusion reaction. So I don't know in 10 years here that I've had anybody get that medicine here. So how do we reduce if we have gout already, how do we reduce our risk of flaring if we have high uric acid levels or we've had gout before? So there is some data to suggest that losing weight, if overweight, is helpful. Diet changes. So again, intaking purines can induce a flare. So a low purine diet, purines are in a lot, so it would be impossible to eliminate. But so like limiting red meat, some seafood, not all. Again, high fructose corn syrup or like sugary drinks, limiting alcohol, beer in particular. The highest risk with that is like if you binge drink or like chronic drink several drinks a day. Beer here and there shouldn't induce a gout flare, though I've had that happen with patients. Um, so limiting alcohol ideally. Just managing kind of comorbid diseases. So you see high blood pressure, high cholesterol, gout often occur together. So controlling the other things is helpful. And then if there are medications that might be affecting the uric acid level, potentially substituting those meds. But again, sometimes that's not an option. If you're on a diuretic for heart failure, then you can't stop it. So I was just going to touch on pseudogout. So pseudogout or CPPD, there's sort of interchangeable names. They're not exactly the same, but so CPPD, calcium pyrophosphate deposition disease. Pseudogout is like when you have an acute flare of CPPD. And so pseudogout is similar to regular gout in that it also can cause red, hot, swollen joints. But there are patients with CPPD who will never have a pseudogout flare. There's something called chondrocalcinosis. So that's sort of this calcium deposit in a joint or in a cartilage, and you can see it on an x-ray. And so someone, they come in, their knees red, hot, swollen, and in x-ray it, and you can see the chondrocalcinosis in there, or the wrist is another common one. So that kind of leads you. And then again, still, aspirate the fluid. But this is different. This typically affects older adults and women and men both. So the knee is commonly affected, again, wrists. So different, most common affected joints with gout or pseudogout. Same thing, we do a crystal exam with this as well because we can see those CPVD crystals on exam. And then the x-ray, you can see kind of the white in the joint space. That's the calcium deposits. Same with the wrist, this space in here, that white fluffy stuff. That'd be that calcium deposits. So treatment of a pseudogout flare, acute treatment, is very similar to treatment of a regular gout flare with a steroid injection, NSAIDs, colchicine, steroids. The difference is that there's not a great way to prevent pseudogout like there is with traditional gout. Sometimes patients with recurrent pseudogout flares can take like a daily NSAID, colchicine, or prednisone, but there isn't any other medication to like lower levels the way we can use allopurinol for uric acid levels. So patient takeaways, now we're back to kind of the regular gout. Patient takeaways, if not definitively diagnosed, like Crystal confirmed, make sure you see a provider so that you can get that joint aspirated and confirm that it is gout, knowing that you may need long-term treatment and not wanting to waste time or money if that's not, if it's not really gout, being on the wrong med. With an acute flare, start treatment ASAP so that the flare can resolve quickly. Again, a low uric acid level during a flare does not rule out gout. Treating an acute flare alone without using those uric acid lowering medicines is not recommended because damage can still occur. And then do not stop allopurinol or similar, if you're on something similar, once you're established on it without direction from your treating provider. So we know that starting allopurinol, stopping it, changing the dose, all those things can induce a gout flare. So that's why it's important to have one person ideally treating your gout, not multiple clinics. And then again, using that prophylactic medicine to help prevent a flare. So any questions?
Is somebody predisposed to pseudo-gout if they started out having regular gout?
No. No, you would not be more likely to have pseudogout if you've had regular gout. Good question. Yeah, pseudogout is fairly common can be associated with just osteoarthritis, like wear and tear arthritis. So again, lots of patients with osteoarthritis of the knees, their X-rays, you'll see the chondrocalcinosis, but they don't necessarily have flares of pseudogout. So I feel like pseudogout, we see a lot in like older women. They'll get like swollen wrists, and you'll see it. And again, sometimes I guess I've seen a nasty pseudogout in a knee. So, but no, they're different, luckily. Yeah. Anything else?